Hello, ladies and gentlemen. Thank you for joining us in the latest of the series of European Society of Regional Anaesthesia webinars. I'm Joe McGeary. I'm currently representing Ireland as a member of the ESRA Trainee and Residence Committee, and I'll be moderating our chat this evening. And our topic this evening is optimizing regional anaesthesia services. And it should be a great interest to every department around the world hoping to improve or implement an applied regional anaesthesia service to a high standard. And we are lucky to have two excellent panelists today to discuss their experiences in this area and answer any questions to the audience. So we'll get straight into it. Our first speaker is a graduate of the Georgetown University School of Medicine. He has completed his anesthesiology training as a resident in Stanford University Medical Center and a pediatric anesthesiology fellowship at Stanford's Lucile Packard Children's Hospital, with a special interest in regional anesthesia and acute pain medicine for children. He is fellow of both the American Society of Anesthesiologists and the American Society of Regional Anesthesia and Pain Medicine. He sits on multiple boards, advisory committees, and professional organizations, and has published extensively in the fields of regional anesthesia and pain medicine. But most significantly, in terms of today's topic, he founded the Regional Anesthesia and Acute Pain Medicine program at University of California, San Diego. So we'd like to extend a warm welcome to Professor Ed Mariano.
Thank you so much. It's always good to be part of the ESRA family and share some of the information that we've learned along the way. It's great to be part of this panel, and I want to thank Joe for inviting me. And obviously we have people from all around the world who are participating. See some friends who've already put some comments in the chat. So yeah, thank you all for joining. We're trying to make this hopefully informative, educational, maybe a little bit entertaining, and hopefully what we'll be able to do over the course of the next within the hour is to have some discussion and interaction. And so please do, like, if you have any questions, make note. You can put in the chat. Joe will be checking the chat, and then we're going to keep our comments fairly brief between the two of us. So that way, mostly just to get people thinking about ideas, maybe some of the challenges you've experienced within your own practices, and then we'll have some discussion at the end. So I'm going to talk about the critical role of communication. And I think that this is something we assume happens, but sometimes doesn't, but why it's such an important aspect to having an efficient and effective block service. I don't have any financial disclosures. As Joe mentioned, I've held leadership positions in various organizations, and I'm currently an editor of Anaesthesia. So I think that we all know that in clinical medicine, we work in an extremely complex system. While we love regional anesthesia, we're all passionate about new blocks and how important it is to do blocks for people. The process of having surgery is extremely complicated. Especially if you think about the episode of care as starting when the surgeon and the patient and patient's family make the decision to have surgery all the way through to their full convalescence. I mean, that is a long time. And obviously, regional anesthesia has a role to play in that, but it is really a restricted period of time when we can have that kind of direct effect. So I think that is it's a good reminder, I think, for us that there's so much more in terms of planning, especially when we think about how to best take care of patients. So this is a quote that I use a fair amount when I talk about systems. This is from George Bernard Shaw. The single biggest problem in communication is the illusion that it has taken place. And I think this is very true. I think that we work in busy environments. We work with a lot of different people from different backgrounds. We work with patients and their families. There is an assumption that communication has happened when maybe it hasn't. I think that that's a good reminder. I just put up a couple of groups that we have to communicate with. And I mentioned patients and families. It is important that we remember that our practice partners within anesthesia are also included there. Surgeons, nurses, therapists, other healthcare professionals, administrators for the hospital. These are all groups of people whom we have to have very good communication. When we think about patient education, I think this is something that we also assume that when we provide informed consent, that we've given patients information that is useful for them and that they can make decisions regarding their own care. We talk a lot about patient-centeredness, at least in the present time with regard to perioperative care. But I think what's interesting, and this is an old study that we did years ago, but I think was very eye-opening in that, when we think, especially as regional anesthesia practitioners, that we're doing this great job of educating people about blocks, and that unfortunately, when we prepare materials, they're often at reading levels that are far beyond what the average person can comprehend. And I think that there are various other ways that we can present information. And while written information is one form of education for people, we obviously have the availability now of many online sources, including videos and even audio educational materials that can be also useful for patients. And perhaps the variety is very useful. But I think it is important. And we looked at some of our subspecialty fellowship programs in regional anesthesia. And even though we have these fantastic programs that are supposed to teach experts in regional anesthesia, even those programs, most of them didn't have any online educational materials related to regional anesthesia, which is shocking because you would think that programs that emphasize the subspecialty training in regional anesthesia would at least have educational materials for patients, so that way patients are prepared on the day of surgery to make these important decisions about their own care. When we look at some of our guidelines and when in talking to patients, I think it is important that we consider available evidence. So when I'm giving patients recommendations about their anesthetic care, and I want to recommend a regional block. So in this case, hip or knee arthroplasty, I can cite guidelines and say, this block that we're offering for you for your type of surgery has been reviewed, and there's evidence that supports that there are benefits in terms of improving your outcomes, which is why this is really part of our recommended care for you. As opposed to saying, well, you could have a block or you could not have a block, and it doesn't make any difference. That's a lot of information for patients and families to try to digest. So I think framing it, when you have the available evidence and you have available recommendations, to present that as part of the informed consent process, I think is very important. So counseling patients with information that now you're having a shared decision-making process because you've shared the information and you're making decisions together on the same information. Now, how does this work within your own practice? So, one of the challenges I find in talking to groups of anesthesiologists, surgeons, other perioperative personnel on setting up anything new, whether it's a regional anesthesia program or something else, is you have to have internal consistency. So this is where it's very important that within your own anesthesia practice, you have consistency in what you plan to offer. And that means that whenever a patient shows up for the same type of surgery, in this case, knee replacement, can you guarantee that regardless of the day of the week, Monday to Friday, maybe even Saturday, if you do elective surgeries on Saturday, any time of the day, whether the patient is first case of the day, whether they're having surgery at 9 a.m. Or at 4 p.m., can you guarantee that what you're offering for each of those patients is going to be the same? And that's a really tricky issue. And so we looked at this within our own practice at our Veterans Hospital, in patients who had one knee done, and then they come back a couple months later, have the other knee done. And it's impressive. This is a good way to test the robustness of your protocol, because if it's robust, and in this case, 103 patients had their surgery on one knee and came back and had the other side done. They followed the same process, and all of the patients got the same multimodal analgesia, as well as they all got the same regional anesthetic techniques. I think that that's an impressive way of testing your own protocol internally. And I do recommend that you do audits like that to make sure that your system is working properly. When talking about surgeons, I would say that their needs are not overly complicated. I think that this is an interesting survey study from now over 2 decades ago, but I love using it because I just think that opinions haven't changed. We just did a combined journal club with our orthopedic trauma surgeons and regional anesthetists and had some discussions about this. And so I can tell you, as of 2 days ago, at least our orthopedic surgeons at Stanford still think that the most important thing in terms of recommending regional anesthesia for their patients is that blocks have to work. And they can't cause delays. So those are their needs. I think they're very upfront about it. And so in designing systems, I do think that we have to have that common understanding of where the priorities are. As I mentioned, I think that this issue of variability, I think, is a problem across the world. And some of these things, I think, can be improved with communication. I think we can have discussions within our own anesthetic practices, as well as with our surgeons, in which we can determine what we consider best care. And once you decide what best care is, then I think that it's really up to all of us to really eliminate that unwarranted variation. That means that there is a such thing as warranted variation. So if you're adjusting your practice based on a patient's comorbidities or the patient's preferences, or even just any situational differences that make this particular case unique, that's fine. That's actually really good because that's personalized medicine. But if none of those things apply, then there should not be variation in care. And I think that that's an important lesson for everybody. When we think about what you offer, so within an anesthesia practice, you have to prioritize what you can do consistently. And so this is just a plug for this concept of Plan A blocks that has been adopted by the Royal College of Anesthetists as part of the curriculum, as well as been adopted in other parts of the world just as a foundational teaching method for regional anesthesia education. Now, I think that the avoidance of complications is critical. So we want to make sure that when you're offering patients regional anesthesia or you're incorporating regional anesthesia in your system, that you're providing all the benefits and hopefully avoiding all the risks. Surgeons are very wary about complications, particularly falls after surgery. And this has really been the push for many of our more selective blocks. There's been an emphasis on motor sparing blocks, which I think is consistent with the rise of enhanced recovery. I think that this process, making sure that you have a system for preventing falls in your hospital is essential. And this is true of patients who have a block or don't have a block, because patients who have their knee or hip replaced, they are at high fall risk no matter what. Patients who are elderly, patients who have cognitive disorders. I mean, these are patients that you should have a fall prevention program in place regardless. So I think that if you have that in place, you have to obviously work with nursing staff. You have to work with other hospital-based personnel. But that really sets the stage for you to incorporate much more regional anesthesia because those safety measures are already in place. I also think that communication and advanced communication really improves your efficiency. I mentioned education. If one lesson I learned as an early career resident in anesthesia was I learned to call my patients the day before if I was going to do a regional anesthetic. And what I found out was if you can show up on the day of surgery and say, do you have any questions about that block that we talked about yesterday? And they say no, then you can get right down to business and start doing that block. So that improves your efficiency right away. If you have a great relationship with your surgeons, if you've come to some understanding about when you're going to do regional anesthesia for which types of cases, then they can even start to prepare patients to expect a block weeks to months before their surgery. That's also very helpful because then you can just ask the patient on the day of surgery, have you been told about the nerve block that we recommend as part of your pain management? And if they say, yes, I've heard of that. And you say, great, you're getting down to business. DJ is going to talk a bit more about block rooms, and so I won't talk about that here. But I think that that is another thing that requires a fair amount of communication and planning, and which is really just to say that there are a lot of people that take care of patients who are going to have surgery. The incorporation of regional anesthesia, while very important, it's really one aspect of perioperative care. This is just a photo that I took on rounds, and we do this system within our veterans hospital where on Wednesdays at 10 a.m. We round as a team with the orthopedic surgeons. So you have orthopedic surgeons, consultants, you have their trainees, you have anesthetic trainees, you have anesthetic consultants, and we have nurses. We sometimes have a physiotherapist. But you see all the patients together, and I think that this is extremely helpful in terms of communication, as well as learning how to prioritize what's important. Many of our improvement projects have really come from this. I think that in the lines of preventing complications, I think having a system where you communicate with each other before you do procedures, stop before you block is a great example of that. That really helps to avoid the potential errors that can lead to wrong-sided block. And then I think making sure when you create systems where different clinicians are taking care of patients at different phases, I think we have to also be very wary of how sometimes communication breakdowns occur. This is a really interesting study that was published in JAMA that demonstrated that at least amongst patients having major surgery, when you had intraoperative handover, when anesthetists are handing cases over to other anesthetists, there were higher rates of complications compared to when there's no handover. And I think that's important to think about. It doesn't mean that we shouldn't hand over cases, but it does demonstrate that the potential for error can come from miscommunication or lack of communication. And so, this is something that we worked on just a few months ago, that it was just released. You see, it's September 2025. Is this idea of having a standardized handoff tool when you use a block room type of a model. So if you have a system where you have a different anesthetist or different clinicians who are taking care of the patient for block, and then you hand that patient over to your colleagues, I think it is important to have a standardized structure for the way we communicate what happened or what took place in terms of the regional block procedure. And so this uses the IPASS tool. The IPASS tool is well established and validated, has been used in other aspects of in-hospital care. But it basically goes through some of the important aspects that may not be in the medical record. And we obviously don't recommend that you just duplicate what's already in a procedural note. But some of the interpretations or observations of the anesthetist during the block procedure, I think are very important to communicate if they don't exist in other aspects of the clinical record. So I think this is just to say that we all want patients to have regional anesthesia. Regional anesthesia for someone who flies a fair amount, I can tell you that regional anesthesia is the business class of anesthesia, especially for certain types of surgeries with the extremities where you can avoid general anesthesia. It's very different, a different experience when you have regional anesthesia, just like it's a different experience when you sit in business class versus in economy or low economy, as many of the airlines have gone to. But in order to make your system work well, I think we basically have to be designers. And what designers do really well is they communicate. They think out loud. They talk about challenges or observations they have. They learn things. They share ideas. They come up with opportunities to make things better. They experiment. They try things. And then they talk about what's worked and what hasn't worked. And then they continue this iterative process. This is something that we obviously can learn a lot from in healthcare. But one of the core facets of success is really communication. So with that, I'll stop. Thank you very much.
Thank you very much for that very informative talk. Just to remind everyone, if you have any questions, please feel free to ask. There's the Q&A button at the bottom of the screen there, and we will get to those at the end of the next talk, and we'll discuss everything so far. So moving on now, we move from California to Hollywood. Of course, Hollywood, Northern Ireland, I mean. Our second speaker is a graduate of Queen's University in Belfast. He completed his anesthesiology training in Northern Ireland and a fellowship, and is a fellow of the Royal College of Anaesthetists in the UK. He also undertook a fellowship in trauma and regional anesthesia in Ontario, Canada, before taking up a post as a consultant anaesthetist in the Royal Victoria and Musgrave Hospitals in Belfast. He has a diploma in regional anesthesia from Ezra and is widely recognised, along with his colleagues, for their work in setting up a highly effective regional service at their hospitals. So with that, we extend a very warm welcome to Dr. David Johnston.
Thank you very much, Joe. Looking forward to this talk, and thank you, Ed, for an incredible talk as well. I think the two presentations will kind of align quite nicely together, and I hope they're serve as use for you guys listening on. Many of you are working already in block room areas or thinking about setting one up. Quite frequently, somebody will get in contact with me and ask me for advice and what are the pointers for setting up a block room, what are the pitfalls that I should look out for. To the point that I decided I would put together 10 practical pointers that I kind of circulate around people that get in touch with me. And these are super practical pointers that I have gathered through trial and error, through successes of my own, but also through failures and things that I've learned from things that haven't worked, just to try and improve the success and make aware of people's pitfalls when trying to set up a regional block service. I have no declarations, endorsements, or conflicts of interest with regards to this talk, and when you see the talk, you'll understand why. We'll understand why. So number one is form your A team. This does not mean get a black van with B.A. Baracus, Spaceman, and Mad Dog Murdoch. This is talking about getting the best people together who are similarly skilled and similarly work in a streamlined way to deliver an excellent service, as you've all kind of know from teams before, and a little bit what Ed was talking about already. Communication is key, and whenever you're working together in a team that communicates well, certain things become very obvious, and a team will work much better when you're not trying to do this by yourself. From a very practical level, regardless of how slick you are at blocks or how incredibly enthusiastic you are, you cannot run a service solo, because you will want at some stage to go off on holiday. You might get sick, you might want to go on a study leave, and if you're there and the service hinges on your own skill set, obviously it will not be robust enough to be carried forward. And so at the very least, you need 2 or 3 like-minded individuals that work well together, that have a good working relationship, and that have a high level of expertise, that will be able to sustain a service if you're not there. A fellowship program also comes into this, where you're then spilling over the skill set onto juniors and trainees coming through towards their end of their training, and you're using the skills that you've been had the privilege to be part of through a regional fellowship. Both myself and Lloyd Turbot that were involved in setting up the block service did regional fellowships in Canada between 2014-15, the same year. And a lot of our skills that we learned through learning from other people, you're able then to teach those to your fellows coming through, so the services are able then to grow and to expand, and that is incredibly important to form your A team. Kind of linked to that is to ensure proficiency, linked again to a fellowship. And ideally, you want to have a fellowship trained leaders in a block room service to ensure that the level of quality in your work is really high. What Ed was talking about before, concerns of surgeons. We found the biggest concern for surgeons was actually their experience of blocks. They were dubious at best and kind of skeptical at worst, whether blocks improved patients' outcomes, whether it improved their pain, whether they were efficacious, or even safety concerns of the blocks themselves, because before this, their experience of radial anesthesia was a rescue block, another rescue block, and then a block rescued with propofol. So the proficiency that we want to deliver in leading a block room service has to be convincing. And if the skill set and the quality of blocks is not there, or if they're taking a long time, or if there's a failed block, very quickly the service will unravel. And just like the Lion's Den, there'll be lots of "I'm outs, forget about it. I don't want my patients to have a block, thank you, but no thanks." So the number 2 is to ensure that you have a high level of proficiency. And again, this relates to having a robust fellowship program as well, so that the fellows that are coming through understand this is the bar at which quality of blocks must be maintained. And it becomes very obvious when you work in a block room environment why that is so. Number 3, again, Ed had touched on this already. This is probably one of the most important parts of a block room service. You need to have a surgeon that has bought into the vision for so many reasons. Quite often, the surgeon will have done their own fellowship in an ambulatory block room environment, so that they have a taste for what the benefits are for patients coming in, having a brachial plexus block in a separate block room environment, and having a parallel processing flow of patients to minimize time delay and to optimize throughput of patients on their operating list. As you heard from Ed, one of the key concerns from surgeons is a delay in theatre, and you can understand, mostly even more so in the private healthcare system, but in the public healthcare system where the resources are so limited already, we don't want to have any higher waste on throughput of patients. The biggest reason you need to have a like-minded surgeon on your team is because a patient has to come to hospital for their operation with the expectation that they're going to be getting a block and having music played in their ears, lying wide awake while the surgery is taking place. And for our system and our model, this conversation happens with the surgeon as they board their patients for a particular procedure. They'll be given a leaflet, and the surgeon will tell them, this is the way that the surgery is going to take place. You'll need an anaesthetist, and for each surgeon, they now are more paired up with their own anaesthetist. So you'll meet Dr. Johnston, and he will perform a block with an injection. Tell them loosely what a brachial plexus block involves, so that when they arrive on the day of surgery, you don't have to start convincing them. They are already aware that this is the way the operation is going to take place, and so there's no surprises with them. And that's kind of a little bit similar to how Ed was talking about the preemptive phone call before. We're very blessed in Belfast because the surgeons will actually tell the patients ahead of time, and you'll even see it on the clinic letters. The patients will be coming expecting a brachial plexus block, so you've no need to convince them. Some will still be nervous, and it's a lot of a different conversation than trying to tell them that you're going to be staying awake when they think they're having a general anesthetic. Number 4, this photo was taken a long time ago, so I look a lot younger, but whenever we were setting up the block room service, a big part of the success of the block room was actually our nursing colleagues, and they are fantastic because they will see blind spots that we get fixated on our brachial plexus block and our ultrasound and our drugs, and we forget about things like patient flow, how the patient's getting down from the wards, how is the training going to be affected for the nurses, what does this look like for the block room area, even things like they keep a record of every single block in a little book, just for the purposes of the fact that they have a complete record of every single patient that's been through. Things like they will match the side of the operation to the setup of the patient's bay where they're coming on. So we're all doing exactly the same setup of the ultrasound machine. Will always be set up on the opposite side of the operation. The block trolley will be set up always on the side of the hand that's being operated on. The IV set will always be set up on the same side as the ultrasound machine. Things that we would, as clinicians, very rarely think about, but the nurses that are very practically minded were very quick to set this up. And I'm so indebted to them because they've saved us so many times and got us out of trouble when we've been venturing towards maybe a dangerous or a hazard. They've already thought of things that we would never think of as clinicians. So I would highly recommend getting the nurses together and bringing them along on the journey, because they're really keen to be involved in new and novel techniques and innovation. So they're such a great resource to have on the same side as you, and it's a big miss if you don't bring them along. Number 5, run a pilot. So if you call it a pilot, no one gets really upset about anything because they're just like, oh, that's okay, it's just a pilot. And meanwhile, this is just a pilot, but I'm actually planning to do this long term. But the principal thing is to call it a pilot because it doesn't intimidate people. People don't get scared. They'll go, it's a pilot. So if it doesn't work, it falls in space. We go back to the way it was before. And in your pilot, you will have already prepared the low-hanging fruit. You've already picked your patients between you and your surgeons and the nurses, the key drivers in your service that you're going to set up. You run a 2-week temporary trial pilot, call it whatever you want, but don't say that this is something new that we're going to be doing from now on. And have all of the easiest patients with the easiest operations locked and loaded, ready to go. That way then, you don't have to sell the service. And what we found whenever we started off and we ran our pilot, we found very quickly that the surgeons seen the surgeon who was championing the awake block service, and very quickly they were, that's something that I want for my patients, because they don't have to go through pre-assessment. They don't have to have the rigorous all the bloods. They don't have to have ECGs and chest x-rays, pulmonary function tests that a lot of the other patients are maybe getting put through. They don't have to wait for a preoperative assessment. They are able to get their patients processed through. The patients are happier, they're content, they're out of hospital quicker, and very quickly, the success and the marriage of a brachial plexus block and a hand operation are a match made in heaven. for an ambulatory service, the service really sells itself, and all you have to do is just to demonstrate it. So run a pilot. It doesn't scare anyone. No one's getting committed. No one's getting confused about that. Number 6 is a follow-up. Really, really important early on, because not just to ensure that the patients are satisfied with what you've done for them, but even for your own well-being, and to ensure that you're kind of reassured that you're doing the right thing for the patients, and particularly for the sore operations, trapeziectomies, wrist fusions, any bony work. You want to make sure that the patients, as they're home, they have been given the right analgesia for the patient, that they have been given the right instructions for breakthrough pain, that they have been reassured themselves that there has been a consultant that have given them a phone call the next day and ensured. Actually, we did a 48-hour. We started doing 24 hours and realized that some of them still had a little bit of new block characteristics, so we changed it to 48 hours. So the patients then knew within 2 days, the consultant's going to phone me, and they're going to know that that my block has resolved, and be satisfied that I'm okay. Simple things like reassuring the patient, yes, there's going to be swelling, yes, there might be a little bit of bleeding, or whatever the reassurance might be. That gives the patient reassurance when they leave hospital, and it also, for the clinician, helps that as well. If it's a phone call, or if it's a online data entry, whatever the follow-up be, it's really important to do that, both from the patient's point of view and from your own point of view, to ensure that you've both done the block satisfactorily, there's no poorly resolving neurology, and that you've given them the right analgesic instructions for home. Sorry, 2 seconds. Once you've done steps 1 to 6, it's time to meet the managers. And the NHS managers get a very bad reputation. So the reason for that is probably multifactorial, but they actually want the same things as we do, but they look through it with a different lens. But if you have done all of the groundwork, where you've ran your pilot project, you have a surgeon who's the champion with you, you have a small team of high expertise, you've been given good feedback, you've been able to show and demonstrate the quality and satisfaction of your patients by your follow-up phone calls, you're well equipped to meet the managers, and to now start to think about putting in a service where this can be run for a long-term introduction and implementation. So it's just practical advice to have on your post-it note before meeting the managers. Have a strategic invitee list. So 1 or 2 anesthetists, your champion surgeon, a nursing representative, and then handpick the directors and the co-directors of the different surgical, nursing, and anesthetic directorates that you want to be there. It's also nice if you have a patient representative there as well, a patient who has actually undergone a block and come to the other side. If you can convince a patient to come along, that gives or even just record a patient if they have their consent, to give them and contextualize what it actually looks like, because managers quite often might not grasp the ins and outs of what it means to have a block or a post-op or any of those types of procedures. If you've got a patient story, it can help. Set an agenda. Don't be afraid to put it on social media. Obviously, no patient details or anything like that, but it's quite acceptable to kind of tell about a new service that you're implementing, and to generate a little bit of excitement about that. Show your pilot results, and importantly, have in your mind what the next steps are, and be confident to ask what you need, because as I said before, this is a really natural fit of brachial plexus blocks and upper limb surgery and ambulatory patients. It will sell itself, but you need to be clear in your mind. What do you need? What resources do you need? Do you need an ultrasound machine? Do you need a recovery space? What particular costs will incur in this service? Number 8, already have the answers for the problems that you put forward to the managers. So in that meeting, you want to have encounter the problems that you've already thought of, and have answers already. Because if you don't have, if you haven't thought of the problems or the shortfalls, it will kind of fox you, and you can get caught out with having a problem without a solution. So preempt your problems with solutions. And the last couple are a bit more lighthearted, but they are important nonetheless. don't sicken people by being really over the top with your blocks. And this is something that is actually that I found out the hard way, because if you come back from a regional fellowship and you think this is the best thing since sliced bread, honestly, blocks are just the best. And actually, what happens is you can completely isolate and drift people away because they just get sickened of it. Oh, DJ's talking about blocks again. Here we go, kind of thing. So don't try and to be too evangelical and try and convince your colleagues about how great regional. Obviously, everyone in this group will know how good it is, but for your colleagues in the department, you kind of just want to temper it a little bit and invite them along just to see what it involves and what it's like. And we're at the stage now that a lot of our colleagues in the department are really confident and in themselves doing blocks as well that maybe wouldn't have been originally, but that just comes with a very slow and steady exposure. So don't go over the top. And lastly, just embrace new ideas. I mean, this is an old picture we took a long time ago, but whatever the new innovations are, if there's VR, if there's new facilities for teaching and training, if there's new equipment or new drugs that come along, if the surgeons are wanting to try something, I'm always wanting to embrace new ideas and be open to that ourselves, because blocks were the new kid on the block for a long time, and it will be something else in the near future as well. So we have to be prepared to embrace new ideas ourselves. So there's my top 10 tips, and I'm looking forward to the discussion and for any questions that come up.
Thank you both very much for two highly informative talks, both very different content-wise, but very much the same themes. I suppose just remind people if there's questions, if you go ahead with the Q&A, but just to ask things off, I suppose, you're both describing, increased patient-centered care, and the big things of cultural change, and cultural change is obviously a huge buzzword in healthcare, but it's not always easy, and that's probably why it's so well discussed. So I suppose I have a kind of two-part question really in relation to that. What unexpected problems did you have? And Dave, you mentioned talking about preempting problems. What unexpected problems did you have when you were setting up the service? And I suppose really, with a bit of hindsight, what would you do differently now if you were starting all over again, in particular?
Yeah. So we ended up actually setting up two block room services. So one was the one that I'm largely was referring to in the talk, which was based in the elective orthopedic unit, and it was a really straightforward success. There was a few you know bumps along the road, but nothing really setback or pitfall wise that we kind of encountered. Our main, then the second block room that we set up was a trauma analgesia block room that we set up in the major trauma ward in the Royal Victoria Hospital. And it was really kind of set up in a similar way, obviously a different patient mix for rib fractures, long bone fractures, pelvic fractures, sternum fractures, where we performed continuous indwelling catheter techniques. And we found that that was a much more of a different feel. The patients were a lot more like kind of more unscheduled, I guess. And it was not as reliably populated with patients all the time. So we found that we were having a block room service, but sometimes the patients weren't available. Sometimes the patients were available and the block room wasn't staffed. And so the pitfall of that one, I would say having a regular scheduled patient input and a regular scheduled anaesthetist performing the blocks is much more preferable. Whenever you have an unscheduled case mix, that can sometimes make it a little bit more difficult to schedule the patients and match a patient needing a block with an anaesthetist. Coupled with that, COVID in the mix of it, we had our pilot running for our trauma analgesia block room, and COVID happened, and it's been a very, very difficult rebuild to get the trauma analgesia block room running again. Principally because it was just a pilot at that stage and it wasn't accepted kind of integrated practice for a regular list.
Thank you. You both kind of hit on, as Dave, you said, you talked about like-minded individuals, and Ed, you talked about internal consistency, which can be tricky in anesthesia, as there's very much different ways and different approaches. how do you come up with the general consensus? I mean, did you find that there's any kind of, how did you reach what was, as you call, like a uniform way and a consistent way of treating patients, or did you have any issues with that?
I mean, I think that the systems really vary of a wide degree. So I would say, uh, in general, and I've had the chance to set up regional anesthesia programs in a couple of places, as well as had a lot of interaction with people from various parts of the world in their own practices. And I have to say that, one of the most important aspects, I think, of just changing anything, whether it's regional anesthesia in this case or something else, is you have to really take some time to observe where the problems are. Like if you think that something's a problem, but no one else, especially none of your colleagues in anesthesia, think it's a problem, then that's probably not something you're going to win. You're not going to get any successes there because no one thinks it's a problem already as it is. So I think that not creating problems, I think, is important. Yeah, there are plenty of problems, right? Yeah, healthcare is imperfect. There are lots of gaps in care. So trying to understand in your own practice environment where you can make improvement, I think, is really key. Yeah, I think that I love DJ's comment about like curbing your enthusiasm. I think is very appropriate. Some of us, especially those of us who have spent a lot of time like learning a lot of these fancy new blocks, and you go to all the congresses, and then you come back and you're all excited, and you say, "Oh, this is the next greatest, latest and greatest thing." You sometimes have to be aware that sometimes alienates some of your own members, some of your own partners. And so I think this idea of coming back to plan A blocks, I think, is key. I think that if you have a practice where you can provide some internal consistency, especially for high volume cases, things that you do a lot of, then that's really helpful. I think that does nothing to take away from the expertise of some individuals, because you do need experts who are able to do some of those more advanced procedures, or especially like try to help when even some of the what we consider more plan A procedures are more difficult. So I think that that's really important, and that helps really keep people on board. So you're already thinking, well, regional anesthesia is important. This is our baseline or our foundational set of offerings. We can do more, but at a minimum, we should probably accept what we think we can offer to all patients.
We've had quite a few questions actually about the follow-up service that you talked about, Dave, in particular. So the first question is, who does the follow-up? And secondly, what do you do if the problems are identified with a follow-up? And I suppose just to add to that, I know you'd said you'd gone from 24-hour to 48-hour follow-up. Sorry, there's a lot of questions there, but what did you find just with 48 hours? Is there anything that you changed after that, after a 48-hour follow-up compared to when you did a 24-hour follow-up in your patient management?
Yeah, so the telephone follow-up calls really were at the very start, where we were consistently calling them to find out, really just, as I said in the talk, to satisfy myself that you'd done the right analgesia for the right operation, and that the patients weren't having too many kind of opiate-related side effects if you'd kind of given them too much, or that they weren't struggling for satisfaction of pain relief because you'd given them too little. And also the number of pills that you've given them home as well, particularly for the more sore operations, and so you've targeted that in a particular way. And it was really just to get a feel for, number one, the analgesia, but probably what you're talking about, Joe, is the kind of the block resolution. Whenever we phoned them at 24 hours, quite often the pain would have been in and around the worst as the block wore off. And so we were finding a lot of the time the patients were kind of, either the block hadn't completely resolved, or they were just saying it was really sore. And so we found it that we were having to phone them up at 48 hours anyway. So we decided that we would just do a 48-hour follow-up phone call instead of the 24. At that stage, then, if you have still some residual neurology, it is worth then doing a follow-up call at another 48 hours, giving them reassurance, saying like there is 1% risk of this happening. The vast majority resolve, so therefore we'll give you another follow-up call in another 48 hours. So again, there wasn't, to my mind, I don't think we had any kind of nerve injuries recorded in any of the follow-up calls. More and more now, because of the introduction of Encompass in Northern Ireland healthcare, this is now being converted. If we call a colleague, Sean Shevlin, who has been actively involved in trying to set up a data capture where patients will be able to do that automatically via their app on their phone. And there's a satisfaction panel, a block resolution panel, and then an analgesic model panel, sorry, that gets input from the patient's end that gets directly then added to their follow-up record. So ideally, that's going to be the optimum to make sure that that we're capturing as much data as we possibly can.
Yeah, I wanted to jump in and pick up some of Clara's questions, just because she put some really good ones in the Q&A.
Yeah.
And I think it really touches on some of this, which is, I think regional anesthesia, one of the exciting things about it in all of anesthesia practice is that it's highly visible. It's something that that our colleagues or patients or families, they see it. They can see it, and they can perceive the value, which is different than a lot of the important work we do in theater is a mystery for everyone. But yeah, this is really something that I think is on the forefront. And one of Clara's questions was, do you see structured simulation training as a cornerstone for optimization? Absolutely. I think anytime that you're trying to learn something new, I think it takes some practice. I think that it is important that you understand the anatomy, the potential risks of any procedure before you do it on patient number one. And there are various ways to do that. I think structured workshops are great, but I also think that if you have an expert within your own practice, then they can also do some of that simulation-based training, practicing on either scanning your own patients. You can do a lot of scanning on patients without actually putting needles in, just so that way you understand the anatomy and where you plan to go. But I do think that that's important. And eventually you have to translate that to, there's always a patient number one. So at some point you take that simulation and you take it to the bedside. She also, she mentions some of the new tools. And I think and DJ mentioned some potential applications to help collect information. I think that's really key. I think that remote monitoring, I mean, with enhanced recovery and now with the rise of day surgery, I do think that anesthetists who do regional anesthesia, I think have a real, a potentially important role, I think, in that patient safety, monitoring of outcomes, patient satisfaction, really as a liaison in terms of postoperative recovery. So I think that those are great tools, not just for better patient care, but also really for advancing the specialty of anesthesia. Other tools like AI, I think, do have some role, and we've seen many of those products come out. Yeah, I think that for experts who do regional anesthesia every day, day in, day out, you've seen all of the variations in perhaps some of the AI generated image optimization or identification may not be as useful if you're truly an expert. But I think if you're an anesthetist who performs a block every couple of weeks or every couple of months, then I think having some of those aids, I think, are helpful. Even just some tutorials. Yeah, I think if you have access to software within your machine where you can have some just-in-time training, or to be honest, if you don't have that on your machine, but you can access online sources of education like YouTube videos. I recommend not all of YouTube is great, but there are some sites like the Duke Regional Anesthesia YouTube channel that has some really good just-in-time videos. I think that would be great. And then the last one I wanted to also tackle from Clara, these are great questions, Clara, thank you. The other one I think is just, what do you do if you had to do one change to implement tomorrow for regional anesthesia delivery? Because not all hospitals, so smaller hospitals may not have block rooms or dedicated regional anesthesia teams. That I think is something that we alluded to earlier, which is figure out what is the problem in your practice. Depending on, it may not be all patients. Maybe you don't try to institute all of Plan A blocks, but let's say that you have shoulder lists 2 or 3 days a week. We know shoulder surgery is extremely painful. And without a block, it's very difficult to manage those patients, whether they're having replacement surgery or arthroscopic surgery. That may be a good source of improvement if you don't currently regularly offer blocks for those patients. And if you are doing blocks and rebound pain is a big issue, that again becomes an opportunity to try to address how best do you approach enhancing your regional anesthesia program. But I would really look at that at trauma hospitals where perhaps you take care of patients with hip fractures and rib fractures. I think that the key is really knowing like where is the big source of improvement where you can make a difference. It doesn't have to be everything, but just take one small piece of healthcare at a time.
Thank you. So just a couple of other questions here. I mean, so what do you suggest about maybe a hospital that's theaters that are spread kind of across the whole complex? Should you have a centralized block service, or do you think that maybe a lot of hospitals ambulatory surgery we carried maybe off-site away from the main theater? How would you tackle a problem like that?
Yeah, I worked in both types. So in Canada, it was a centralized kind of hub and spoke kind of model where there was one block room, which fed off all of the different patients, mostly to an arthroplasty ORs, which had the great benefit for me as the fellow because you got to do all of the blocks, particularly for lower limb. It was in place I worked, and also the spinals. So in the block room, you maybe had 4 or 5 neuraxial anesthesias going in one time, along with all of the blocks. Now that was great because you got your numbers to swell very quickly. It felt a little bit like you were running 4 different anesthetics at one time as you were having spinals put in one place, which was less ideal. But because the surgeons' buy-in for the block room there was turnover of patients, the way that they got their buy-in for the surgeons was by allowing the anesthetic, the neuraxial spinal anesthesia, to be put in the block room. And so you had a little bit of a pressure where you were maybe running around giving some IV fluids or phenylephrine for patients that had a little bit of a blood pressure dip following a spinal. The model that I work in currently is where you have a block room area in recovery, and you have the one anesthetist that goes into the block room area will block the patient for their list. The patient will come into the OR, and then you'll go back out after the knife to skin to go out and block the patient that is next on your list, so that the patients will run in continually in a parallel processing style with minimal turnover delays. The benefit of that is that you don't have the system where you're looking after multiple different patients. The downside for that is you're only performing one block, so you could potentially improve efficiency by one anesthetist providing blocks for different ORs. It's a slightly different model in Northern Ireland because we just have one anesthetist to one theatre. So it's not actually any benefit. It doesn't provide any benefit for us to have one anesthetist performing blocks for several different theatres. We got buy-in from the recovery nurses to help us out to perform the blocks in the block area of recovery because it circumvented the patients going to recovery afterwards. So the buy-in for the nurses was, we'll give you a hand at the start to put the blocks in so that we don't look after the patients afterwards. They go straight back to the ward instead of going to recovery. So they were basically taking the after bit of the recovery resource and front loading it onto the block room time. So it was kind of basically cost neutral for them in terms of a nursing resource. That's my experience between the two different types of block room models. Ed, what way is yours?
Yeah, I think it's very, as you mentioned, I think it's very dependent on the footprint. And I think that to the question, I mean, when you have 3 different areas of surgical areas within your institution, and they're not that close to each other, and then sometimes logistically, it's difficult at times to have a centralized block area. Not impossible. You can organize. It takes a fair amount of organization. I think if you follow the top 10 tips, I think that's one way you could probably do it. But there are institutions, and I think Mary Hargett from Hospital for Special Surgery is online as well. I mean, if you have, say, for example, an institution that's orthopedic surgery focused, and you imagine that you have over 30 something operating rooms, with orthopedic surgery happening at the same time, then that type of a model would not be amenable to having necessarily a centralized block room. It's just too much volume. So in practices like that, then you hire anesthetists who know how to do regional anesthesia, and they can do it effectively. They can do it fast. There are varying models, and I think if you have multiple sites like that, you have to decide if logistically it makes sense where you can have some of those blocks performed in a centralized area. That's great because you get all the benefits of the parallel processing. But if 1 or 2 of those other areas has either lower volume and or longer turnover, then you may be able to staff those with the anesthetists who are already in those locations. I think that with all things, I think another question had asked a bit about resources and setting up. I think you have to figure out within your own system, what the cost to benefit is, and the more you can maximize the utilization of your staff and space, the more cost effective it is. So if you have, say, for example, 1 or 2 theaters that have maybe 1 or 2 blocks each in one location, having a separate anesthetist may not be as cost effective, but you have to decide whether that makes sense. Trauma lists are challenging only because they're inherently unpredictable. But I think if you have someone who's like your free agent or board runner, then that may be something that maybe that role gets assigned to someone who can do regional anesthesia.
Thank you. So time is kind of running out. There's a couple of interesting questions just to quickly run through. What metric do you think best demonstrates the benefit of a regional anesthesia service? Is it patient outcomes, throughput, cost savings, staff satisfaction? What would you maybe recommend people use to sell it to their prospective department heads,
Yeah,
etc.?
I don't think there's any one particular one of those that stands out more than any other ones. You could make an argument for any of those being the marker of a quality of your service. There's obviously ones that would be of an adverse quality, that are markers of the fact that you're not providing a good service. Unexpected conversions to general anesthetics, unexpected attendances to ED with pain following surgery, nerve injury, those types of things would be markers that there's something that's not good in your service. So you would kind of pay caution to those. But I think the ones that you mentioned, Joe, I think it's a combination of all of those outcomes. You want to ensure that patients are satisfied when they go home, that they're functionally good. You want to make sure that there's been no delays in the operating turnover. Again, staff satisfaction is actually probably a really high indicator of how your service is running, because if your service is fraught with frustration, delays, the nurses or the surgeons are aware that the patients aren't happy, they become unsatisfied with the service that you're running as an anaesthetist. I quite often think staff satisfaction is a really key outcome to see how effective your service is running, particularly recovery staff, because they obviously see the patients now before with us, and they can see the patients after, if they're up in the ward, and they can get a real grasp that actually you're delivering a good service with good outcomes for the patients, when the recovery staff and the theatre staff are satisfied with what you're running.
I suppose the final question, do you recommend that, the block service is broad, that you provide a multitude of blocks, or should they maybe, focus on upper limb maybe first, or just supply a full service as a whole?
I mean, I think it really depends on one, on what you're starting with. So I think that if you have really no regional anesthesia services currently available, then I think it is helpful to start relatively small. I mean, you want a trusted group of surgeons and staff who really believe that this is something that's going to add some value. I think in some ways it's an ideal situation, because you can also you can decide like which metrics you want to collect. And I do recommend that you start to collect metrics like satisfaction, quality of recovery, functional measures, pain interference, like how well people sleep after surgery, how often they wake up, how does pain affect their mood and activity. Those are things that I think that are helpful to collect at baseline, because oftentimes this is true all around the world. Whenever we come up with improvement projects, we start collecting measures after we've intervened. And so you have nothing to compare it to. And I think it's very convincing to have some baseline measures to compare to. I think if you have support, and that this is where I think sometimes we've seen some examples where, especially in North America, where we've had opioid overprescribing, we've seen funding offered to facilities to try to establish programs. If you're in that kind of a situation where you can apply for external funding, then I think that your scope could be much larger. But I do think that one important consideration in one of DJ's top 10 is don't overpromise. So one of the things, even if you have funding, I do think that it's helpful to start with a pilot. Don't overpromise, collect good measures, and then incrementally increase.
Perfect. Well, I think on that note, we might finish as time's run out. There's still a few questions there, and I'm sorry we can't reach everyone. It's obviously a very important topic, but it's great to see so much interest. I suppose just to quickly summarize from key points there, the consistency and standardization was key that you both mentioned, and kind of like-minded colleagues, as you say. And as you said, knowing that the days that you're not there, that the same service is still going to be provided, and having that sorted. Education, not only of your patients, so we talked you talked about, calling them the day before and letting them know about the block, but also the surgeons letting them know at the clinic, or even when they're coming in, that they're going to get this, and that way there's going to be a nice streamlined run through service. But just to say on behalf of Ezra, thank you both for giving us your time, and it's very, very much well appreciated and very well received by everyone in our chat here. The comments are still coming in, and I want to wish you both well. A good evening to you, Dave, and
Yeah,
happy rest of the morning for you, Ed.
yeah.
And thank you both very much for your time.
Thanks, Joe.
Great job
Appreciate it.
moderating. Thank you so much.
Yeah,
Thank
great
you.
job.
Thanks,
Thank you, Joe.
guys.